Hi, everyone. I'm Erika Blacksher, John B. Francis Chair in Bioethics at the Center for Practical Bioethics and Research Professor in the Department of History and Philosophy of Medicine at the University of Kansas School of Medicine. This talk is an abbreviated version of a grand rounds I recently gave at the University of Kansas, where I talked about a new project called Building a Circuit of Civic Learning, Dialogue and Connection to Advance Health Equity and the Health of All, a Democratic Deliberative Model, Materials, and Metrics. We just learned that the first phase of this project has been funded by County Health Rankings and Roadmaps, a program directed at the University of Wisconsin's Population Health Institute with support from the Robert Wood Johnson Foundation. In this talk, I'll describe the project's hypothesis, its hopes and challenges, all of which will require that I introduce you to the core tenets of democratic deliberative theory and practice, and how those commitments translate into the design and conduct of actual deliberations. The considerations we'll have to take in mind when we're designing how we're going to convene people. I'll conclude by noting the remarkable people who've joined me in this endeavor, and I'll begin by briefly describing the impetus of the project, which is twofold. The first motivation for this project relates to the poor state of the nation's health. We all know that COVID-19 has delivered a massive body blow at the US. It's caused a 1.5-year decline in overall US life expectancy, and it's killed, as of today, something like 653,000 people. The pandemic has not been an equalizer, as some suggested in its early days. 95% of deaths have been in people 50 years and older, and it has taken a disproportionate toll on Black, Brown, and Indigenous people, and poor people, no matter their race. But long before the pandemic, researchers have been sounding the alarm about the poor state of our nation's overall health, significant race and class-based health inequalities, and declining life expectancy. Report after report has documented these realities. Here's just a sampling of our health troubles, some of which you may be familiar with. When we compare America's health outcomes to those of our peers, some 16 other wealthy industrialized nations, we suffer what experts call a health disadvantage. This health disadvantage begins right away in US infants who begin life with a shorter life expectancy and are less likely to reach their first birthday than newborns in other wealthy countries. That disadvantage continues into adolescence, with US teens experiencing higher rates of vehicle crashes, homicides, pregnancy, and sexually transmitted diseases. We have the highest incidence of AIDS and the second highest prevalence of HIV infection. We have the highest prevalence of diabetes, the second highest prevalence of obesity, and the second highest rate of death from heart disease. We also suffer more lung disease and drug-related deaths. Those drug-related deaths are a significant contributor, though not the only contributor, to our stalling and now declining life expectancy. Other causes of our declining life expectancy include diseases of the heart, lungs, digestive systems, and other organs, as well as rising death rates during pregnancy and early childhood. People worry about the fact that our life expectancy is decreasing because it tells us about both the health and well-being of a population, the United States, and overall social and economic conditions. When it declines, as is the case for America, it signals worsening social and economic conditions. Researchers worry even when life expectancy stalls, that is, stops increasing, because that is what has typically been the case for many, many decades. It keeps ticking up, but now ours is declining. US life expectancy is some 3 to 6 years less than that of our peer countries. These miseries, poor health and premature death, are visited disproportionately on the shoulders of Black, Brown, and Indigenous people, and poor people, whether they're white, Black, or brown. People worry about health inequities because they truncate the life opportunities and productivity of people who are already socially disadvantaged, and many people view these health inequalities as unjust. Now, while the causal stories for these outcomes are complex and not entirely settled, there is plenty we do know and plenty we could do if we had the collective will. And that brings me to the second impetus for this project, the poor state of our nation's civic health. By civic health, I mean our ability to learn and talk together with mutual respect and concern on the basis of shared facts in search of common purpose. To talk with a sense of we about the big problems we all face. And our population health challenges are big. The remedies outlined in dozens of the reports, some of the covers you see here, they're not Band-Aids. They're fundamental and include addressing issues such as high rates of adult and child poverty, limited access to quality childcare, low levels of social mobility, employment and labor protections, fragmented healthcare systems, chronically underfunded public health systems, built environments that are designed for cars, not people, and the protections of every citizen's right to vote. And across all of these domains, racial disparities. But the prerequisites of such big, civically minded work are in very short supply. Trust is essential, and trust in the government and science and expertise and in one another is at a low point. The Pew Research Center recently conducted a survey of trust and distrust in America, and it documents just how dire the situation is. Here are a couple of quotes from the recent survey that I've chosen because I think they illustrate key facets of the obstacles we face, and they're important to the project that's just being launched at the center that I'm going to describe in just a minute. The first quote says, "Many people no longer think that federal government can actually be a force for good or change in their lives. This kind of apathy and disengagement will lead to an even worse and less representative government." Second quote reads, "As a democracy founded on the principle of e pluribus unum, the fact that we are divided and can't trust sound facts means we have lost our confidence in each other." And that brings me to our project, which uses deliberative democracy to advance civic learning, talking, and engagement around population health challenges. The question that motivates this project is this: how do we build trust, shared knowledge, civic practices, and shared purpose to advance health equity and improve the health of all? The project's hypothesis is that under good deliberative conditions and equipped with nonpartisan and plain language materials, people with varied identities and varied interests can learn and talk together with mutual respect and mutual concern and find common purpose on population health challenges. Now, today, I'm focused on describing the project's first phase. It's the bottom rung of the project, that bottom dark brown piece of the schematic, which we believe we can accomplish in a year's time, during which we will build the tools that are then used to convene people for learning, talking, and connecting in remaining years. Now, let me turn to say more about what deliberative democratic theory and practice is. The basic value proposition that underpins democratic deliberation is that people should have meaningful opportunities to participate in important social decision. The idea is rooted in political theory, moral theory, and communication theory, and makes the case in various forms for an informed and active citizenry that's deeply engaged in its own governance. These ideas, which are the stuff of many scholarly books, articles, and conferences, have also spawned a wellspring of civically oriented participatory activity around the globe and here in the United States. There are organizations devoted to teaching people how to deliberate and that create space for people to deliberate. Handbooks have been written on why, when, and how to do it, and deliberative experiments have proliferated and travel under different names, such as citizen juries, citizen assemblies, planning cells, national issue forums, deliberative polling, and more. All are aimed at convening ordinary citizens to learn about, discuss, and debate, and weigh in on important issues that sometimes affect them in quite specific, direct ways, or sometimes more generally as citizens. Now, there is no consensus definition of democratic deliberation, or what is sometimes called public deliberation, but when one looks across several widely cited definitions, one finds overlap in meaning. We can start by saying that public deliberation is a substantive form of public discussion that seeks collective solutions to challenging social problems that are value-laden and involve normative trade-offs. To flesh that out a bit more, that second quote tells us that public deliberation aims at producing reasonable, well-informed opinions in which participants are willing to revise preferences in light of discussion, new information, and claims made by fellow participants. This quote speaks to the transformative potential of democratic deliberation, by which I mean the fact that deliberation produces something beyond top-of-mind opinions, the sorts of views we get with surveys, focus groups, or town halls, all of which have their place but are not democratic deliberation, which, because people learn from information and learn from one another, their views may actually shift or change, or if not change, they get greater understanding of other people and sometimes more insight into why they think what they think. Now, to these quotes, let's add a third, which is that public deliberation engages ordinary citizens with diverse perspectives in reasoned and respectful discussion about important social issues in search of well-informed proposals that deliberants will view as legitimate. This quote foregrounds three things. First, that participants should be diverse and have diverse perspectives and diverse backgrounds. It also suggests something about the form of discussion, that people engage each other as morally serious persons, as people with values and reasons for their positions, their viewpoints, that they can and that they're willing to share. And finally, it speaks to a much sought after outcome, namely that participants will view the process of talking, of conversing, of dialoguing as fair, regardless of whether they agree in whole with the results. At the heart of democratic deliberation is a normative ideal, namely that people are engaged with mutual respect as free and equal citizens in search of fair terms of cooperation. Now, when should democratic deliberation be used? It shouldn't be used for every problem we face. And these are some of the characteristics that are perfect for using deliberation. When a social challenge, a social problem, a public policy issue has one or more of these characteristics, democratic deliberation is very good to use. When there are conflicting or competing values, when the normative trade-offs need to be made, when we can't do it all, and so we have to choose among our priorities, when an issue is controversial, sensitive, or divisive, and when the issue requires real-world knowledge, lived experience, the social values of everyday people, when technical experts alone can't solve the problem. And finally, when there's low trust in government, research, medicine, or whatever social sector that the problem is relevant to. Finally, let me note that the rise in deliberative experiments in the United States and around the world is part of a broader participatory turn, a recognition in many democracies and sectors that better, more sustainable, and more just decision-making and policy-making can occur when people have a say in it. We see this trend in the US health sector, reflected in numerous efforts to learn from and center the voices of patients, communities, and citizens, as reflected in things like community advisory boards and community-based participatory research, and the creation of patient-centered outcomes research. In fact, democratic deliberation, as one piece of this participatory turn, has garnered so much attention that the Agency for Healthcare Research and Quality, which we call AHRQ, funded a randomized controlled trial of deliberative methods, and it yielded quite good results. I wasn't part of that study, but I was invited to comment on it at an Academy of Health panel where its results were presented in 2015, and we've seen quite an uptick in use of it. Now, against the backdrop of this quick overview of democratic deliberation, let me say more about what these ideas and ideals mean when planning to create a circuit of civic learning, talking, and connection on population health challenges. Recall for a minute that the project's hypothesis is that under good deliberative conditions, people will learn, will trust the evidence, will engage with one another in good faith in search of shared solutions. So what does that mean in terms of deliberation design? I have been involved for the past 6 or 7 years in the design and implementation and assessment of many deliberations in varied contexts with colleagues across the country. And over the years, I've come to think of the deliberation design as involving 3 components, each of which is informed by the values and commitments of democratic deliberation that I just described. The first component is what I call the model of deliberation, which refers to who will be recruited for what number and duration of deliberations, whether people will engage in enclave deliberations as well as mixed deliberations, how deliberations are facilitated, and what sort of talk is actually considered deliberation. And let me start by saying it's imperative for deliberation to involve people who are very diverse, come from varied backgrounds, different sorts of identities. The goal is to ensure that people bring diverse perspectives and viewpoints on the backs of lived experience to be a part of that dialogue, so people can learn from people who are not like them and learn about other perspectives. The goal is often to have a representative sample, a group of people that accurately reflects the characteristics of some population, say the people of Kansas and the people of Missouri. Now, that can be difficult because face-to-face deliberations are typically small in number. So the goalposts sometimes move to ensure that there is a rich diversity of perspectives in the room, even if it is not a perfect representation of the characteristics of the relevant populations. And the nature of the diversity that matters may vary from project to project, depending on the topic at hand. For this project, it'll be essential that deliberants are racially, ethnically, socioeconomically, and geographically diverse and represent a wide range of ages, given the nature of the population health challenges that we face. And this issue also raises questions about power dynamics and power imbalances that can occur in the room, a serious concern for deliberation, which seeks to ensure that people have equal opportunities to participate and feel comfortable talking. Power imbalances can occur for many reasons. Among them, some people simply may be more practiced and have had more opportunities to voice what they think and why they think it. They may have more education, for example. And there are diverse forms of expression. People are more comfortable telling stories, perhaps, or citing evidence. And also, deliberative norms may be contrary to the cultural practices of some people. In deliberation, we respectfully disagree, and we point out why we disagree. And that may be uncomfortable for people who are from cultures where it's inappropriate to disagree in public or with an elder, for example. So there are many tools to address this, and deliberative theory and practice have evolved over the years to understand that if we truly want diversity in the room, and if we want to hear everyone's voice and not silence some people or privilege other people, we need to invite storytelling and testimony into the room. That people getting emotional is certainly reflects reasons, and that's acceptable. Sometimes people use enclave deliberation, or what's sometimes called mini publics, which is bringing people together who are, for some points in the broader circuit, to talk with people who are more like them than different. And then once people have had an opportunity to sort of gain their deliberative footing, if you will, learn about the issue, get comfortable talking about the issues in that safer setting with people like them rather than different from them, then you begin to incorporate them into mixed deliberation. There's some quite good evidence that can be quite successful, and we'll certainly consider that in this project. Another thing to think about is how long do we bring people to deliberate? Certainly, that's a question, for each and every deliberation. But deliberations, they can be as brief as a few hours to several days, and then you bring people together over and over again, maybe every other month for a year. There's considerable variation, and so we'll have to think about that. But one of the things that the ARC controlled trial showed is that while even brief deliberations can be impactful and be good, the longer people are together, talking and learning from one another, the better the results, the deeper the learning, the more they understand, and the more they're impacted by the conversation. There's also the question of convening people in person or online, and certainly during the pandemic, we've learned that we can do some things quite well online, but there are deliberation scholars and practitioners, myself among them, who believe there are some things that just don't happen as well online as in person, that some things occur when we're actually together, looking each other in the eye and talking. But we've also learned that there are some things that can happen very well online. So that'll be another thing we'll need to think about as we design these deliberations. And then the issue of facilitation matters as well. There's sometimes sort of very quiet facilitators who sort of just let a conversation unfold. I tend to be a fan of more active facilitation that ensures people feel included and that space is created for all. I like to have people dip back to make sure we circle back and get sort of go back to issues to understand not only what people think, but why they think it and whether their ideas have changed. And then to encourage crosstalk among the deliberants so that people aren't just talking through the facilitator, but rather talking with one another. It's always my favorite moment in a deliberation when I see deliberants respectfully engaging one another, and the facilitator can kind of just stand there and watch this very good dialogue take place. The main point here is that an enormous amount of thought goes into planning the nuts and bolts just of the circuit of learning and how the conversation will occur and who's in the room doing what, to make sure that all feel welcomed, people are able to learn in the absence of fear or domination, and talk in ways that are natural to them yet respectful to all. And all this is to try to take seriously an important critique of deliberation from some heavy hitters that, despite its egalitarian intentions, democratic deliberation may marginalize or silence the views and interests of minorities, those who are resource poor, those who are vulnerable, and thereby reproduce entrenched inequalities. We also want to make sure that democratic deliberation doesn't overlook or distract from essential and just as important democratic forms of action in the pursuit of a more inclusive world, a fairer democracy. The second component is that of deliberative materials. And here, several elements are really key and will certainly be challenging in this project. Deliberations are formed around questions that are civically oriented. What ought we to do about X? So it's inclusive, and what questions we choose to frame the deliberations will need a lot of careful consideration. You also need to think about where you're pointing deliberants. Do you ask them from the get that the goal is consensus? Many deliberations do that, and for good reasons, depending on the question and the context. I tend to prefer to frame deliberations in terms of seeking to understand where there may be agreement, where there may be disagreement, and with that, then learning where there may be common ground. That, again, will be something we'll need to think closely about in this project. And then finally, and certainly not lastly, because it's going to be a huge challenge in this project, which is the materials and the case studies that inform the deliberants themselves. The experts, perhaps, we invite into the room. They need to be balanced. They need to be nonpartisan. Where there is disagreement, you need to make sure you have experts in the room representing all the views. And so for the materials themselves, what are sometimes called briefing materials, which are sometimes sent out in advance and then revisited in the deliberations themselves, and for the case studies that will inform their thinking, there's a lot of rich science that I think we can use to inform the development of these materials, what I call intersectional health studies, which I'll speak to in a minute, political science, where there have been some important lessons learned about how to talk about race and class in a way that builds joint purpose rather than is divisive. Communication science that tells us we should talk about the full array of health determinants, from those individual health behaviors to more meso and macro level structural determinants, and what we've learned from social science about Americans' notions of fairness, some of which I've conducted, that tells us that Americans are, despite what we might think today, very committed to ideas of fairness, but that the bulk of Americans, not all, but the bulk of Americans, when they think about fairness, they're thinking about equality of opportunity rather than equality of outcome. Now, let me just note some of the challenges here in terms of thinking about how to develop these materials in a balanced, nonpartisan way. Population health has in it, integral to it, I should say, epistemological assumptions, normative concepts, empirical realities that have been sadly highly politicized. For example, the fact that social structures exist and causally contribute to health outcomes. We know that from population health science. As an example, structural racism is real. It exists and it contributes to health outcomes. The other factor here is that health inequities track with racial, socioeconomic, geographic, and cultural differences that have been used to divide the American people. So the challenges here are not trivial. But again, I think we have resources that can come to our aid. And here I'm just going to refer to a few of them, one of which is what I'm calling intersectional health studies, which are those that bring together around some health outcome, whether it be life expectancy or preterm birth, which is a major contributor to infant mortality, or early life adversity, bring together race and measures of race and measures of class. and perhaps other relevant differences such as gender or immigrant status. And I want to just say here a word about why this matters. And I'm going to use a quote from Nancy Krieger, who wrote this some 30 years ago. She says, label infant mortality a problem of minorities and present data only on racial, ethnic differences and rates, and the white poor disappear from view. Label it a poverty issue and proffer data stratified only by income and the impact of racism on people of color at each income level, all up the socioeconomic ladder, is hidden from sight. Any particular approach to how we represent data necessarily affects our ability to understand and alter social inequalities in health. And we have other resources to draw on, such as the County Health Rankings and Roadmaps program is full of information and things such as this logic model, as they call it, which represents a full array of social determinants, including health behaviors, clinical care, social and economic factors, and physical environment, and then breaks those down at a more granular level in quite digestible bits, and even on the basis of a lot of science, describes what portion health behaviors contributes to health, what portion of clinical care, and so on. And so resources like that already available to us in the County Health Rankings and Roadmaps program will be very, very useful. The final component are the deliberative metrics that one uses to measure whether the deliberation has been successful. And I've suggested three categories: knowledge gains, deliberative gains, and civic gains. In terms of knowledge gains, for example, I mean things like the degree to which participating in the deliberation improves participants' understanding of the social contributors to health and just the construct, the notion of population health itself. And no doubt there'll be other things we'll want to measure. Deliberative gains, things like whether people truly felt they had an equal opportunity to participate, whether they felt there was mutual respect in the conversation. Importantly, whether people felt there was respect in the context of disagreement, something that, at least for some in America, is not, shall we say, not something we see often. And then civic gains, things like interpersonal trust. Does participating in this circuit of learning and dialogue and connection, does it increase trust? Does it increase trust in evidence? So none of this will be easy. There are challenges in each component of the deliberation design. But the good news is that there's a remarkable group of people who've agreed, who've signed on to work with us on this project. And I'd like to quickly tell you who they are. The research team, there's a research team, there's an expert advisory committee, and I could not be more excited about who these people are, some of whom I've worked with before. On the research team, and including, in addition to myself, is Dr. Yukiko Asada, who's a tenured professor at Dalhousie University and now a visiting professor at McMaster University. She's trained in many things that are essential to this project, and she's one of those rare researchers and scholars who is equally adept, whether we're looking at quantitative or qualitative work or the ethics of the issues. And she's also one of only two people that I know of who have used democratic deliberation in the context of population health. The second person is also on the research team. I feel very fortunate to have Dr. Marion Danis on board. She's at the National Institutes of Health, where she's the head of the Ethics and Health Policy section. And finally, but not lastly, is Jaron St. Ange at the University of Kansas, who's an associate professor both in the Department of Sociology and the Department of Population Health. And his training is wide and extensive and will be essential to the project. I won't go through each of the talents of everyone on the advisory committee, but I would like you to take a look at them, and I'll read their names. They're experts from across the country with a concentration in Kansas and Missouri. And they are Dorothy Daly, John Gosteel, Tony Gates, Dee Rashawn Gilmore, Marge Ginsburg, Jason Glenn, Martha Gold, Hetty Lee, Andrea Perdomo Morales, Tony and Richard, Bobby Sonke, Lancer Stevens, Bob St. Peter, and Sean Baez. Let me just conclude with one final note, which is to say that The issue of civic infrastructure and civic engagement and its impact on health and health policy and health equity is garnering a lot of attention. The National Academies of Science, Engineering, and Medicine just hosted 2 workshops on the subject, one of which I had the pleasure of being involved in planning. What studies show is that the more engaged and informed a citizenry is, the more people have the opportunity and to feel capable of participating in deliberative venues and showing up at the ballot box to make their voices heard, the healthier they are. It is my hope that this project can make a contribution to building a more informed and engaged public in Missouri and Kansas so that all can be healthier. Let me thank you for your time and attention. And I never talk about democratic deliberation without thanking countless colleagues, partners, and deliberants from whom I've learned so much about democratic deliberation and its possibilities. Thank you.